Dear doctor friends, today I am going to talk to you on the topic deep vein thrombosis, commonly referred to as DVT. There is a paradigm shift in the diagnosis and treatment of DVT over the past decade. It is important for us to imbibe these changes and be updated with the diagnosis and treatment of DVT. This presentation is available on our website www.drsharma.in. In addition to this, many other previous presentations and valuable medical informations are available on the website. Please visit the website. Before we go on to the topic of DVT, let us spend a few minutes on a common condition called the varicose veins. Majority of us have seen patients with varicose veins. Varicose veins affect about 1/3 of all adults. There are no symptoms attributable to varicose veins alone, and they are very harmless in most patients. There could be discomfort, itching, sometimes aching and swelling of the limb after prolonged standing in people who have varicose veins. Usually it is associated with increasing age, family history of varicosities, obesity and in pregnancy. Sometimes these varicose veins can predispose to skin ulcerations and thrombophlebitis and deep venous thrombosis. Varicose veins per se are not dangerous, but if deep venous thrombosis develops, that could be potentially harmful. Compression ultrasound is required to assess for DVT in varicose veins. Barring that, varicose veins per se are generally benign conditions. Venous thromboembolism, frequently referred to as VTE. About 2/3 of the patients of VTE have deep venous thrombosis. Remaining 1/3 are patients of pulmonary embolism. So the term VTE encompasses two different conditions. One is a deep vein thrombosis of the limbs. The other is the more dangerous and fatal condition, pulmonary embolism, arising out of the patients of DVT. Venous thromboembolism is associated with higher mortality and morbidity. 6% of the patients of DVT and 12% of the pulmonary embolism patients die in the first month. Incidence rates of DVT and PE are higher in men. Africans and Indians are more prone for these conditions. VTE increases markedly with age. It is strongly associated with immobilization of the limbs, particularly fractures and surgery. Some more facts about VTE. 10% of the hospital deaths are attributable to VTE. Majority of the events are clinically silent. That is why we do not know for what cause the patient died. Most likely it is the underlying VTE with pulmonary embolism and infarction. Symptomatic VTEs occur long after discharge from the hospital. Patient would have been discharged fairly well from the hospital, but in the week next he succumbs at home, probably because of the underlying DVT which has resulted in pulmonary embolism. Risk factors for DVT and VTE are class 3 and class 4 heart failure, COPD and sepsis are additional contributory factors. Prophylaxis with low molecular weight heparin (LMWH) is recommended for all patients of CHF, COPD and in patients with a high risk of VTE like cancers, inflammatory bowel disease and sepsis. Prophylaxis can be given with LMWH, namely enoxaparin 40 milligrams given once a day as injection subcutaneous along with compression stockings, also called TED stocking. This we have already discussed. 67% of the venous thromboembolism is because of deep venous thrombosis. 33% of the VTE is the fatal pulmonary embolism. This graph summarily states the fact that as advances, the risk of VTE is higher and higher. From 45 to 54 age group, if we move on to the 75 plus age group, the risk of venous thromboembolism increases, more so in men dramatically after the age of 65 to 74. In this presentation, we will mainly focus on our attention on deep venous thrombosis and will not touch upon the more morbid and dangerous pulmonary embolism, for the very fact that deep venous thrombosis is what we are supposed to identify and treat and prevent pulmonary embolism. Pulmonary embolism is in the purview of specialists. So let us look at DVT as the most important thing for us. Formation of blood clots or thrombi in the veins, often in the deeper veins of the legs, thighs or pelvis. Patient may experience pain, tenderness and swelling and inflammation of the area of deep venous thrombosis. Once the thrombus sets in there in the vein, it can lead to post-phlebitic syndrome. The thrombus can get embolized into the pulmonary circuit and cause acute pulmonary embolism and infarction of the lung. It can result in death. Look here, the picture shows a blood clot in the deeper veins of the legs, of the thigh in fact. DVT, 70 to 80% of the DVT is recognizable in the proximal veins, most commonly involving the superficial femoral vein or the popliteal vein. That is, the proximal part of the lower limb is the site of DVT in majority of the cases. In around 20 to 30% of the cases, the DVT is detected in the veins of the calf muscles, the anterior tibial vein, the peroneal vein and the posterior tibial veins. What are the risk factors for DVT? There are certain patient factors, certain modern factors, certain acquired factors. Previous history of DVT is a high risk factor for recurrent DVT. Increasing age over 40 years and above, particularly over 60-70 years. Pregnancy itself is a predisposing condition for DVT. Genetic predisposition for DVT is another important patient factor. Modern factors like prolonged air travel, wherein the legroom is much less and the patients will suffer DVT after prolonged travel because they could not move their limbs during the travel. So much so, there is stagnation of blood in the lower limbs which has resulted in DVT. It is said that among the people who fly out of Heathrow Airport in London, at least one person dies every month due to DVT. Another important factor in the modern day world is the e-thrombosis. People who get addicted to computers and laptops go on sitting in the browsing centers for hours and hours without moving their feet and legs. They tend to develop DVT. Another important factor is the estrogen therapy. Women on estrogen replacement therapy are at a higher risk for deep venous thrombosis. Acquired factors like immobility caused by fractures, caused by inpatient care, and then cancers, inflammatory bowel disease, oral contraceptives, varicose veins, obesity, recent surgery and confinement to bed, major trauma, lower limb injuries, dehydration. These are some of the other factors which can result in DVT. Okay, what are the clinical features of deep vein thrombosis? In this particular disease, it is very important for us to use the prediction score rather than to go by one or two clinical signs. What is this prediction score like? This is called the Wells prediction score, which we will be discussing in the subsequent slides. However, the following are some of the important clinical features of DVT. A history of recurrent DVT is a strong predictor for deep vein thrombosis. Presence of one or more of the risk factors which we have listed in the previous slide is also an important parameter. Leg pain is present in about 50% of the patients of DVT. The most important striking clinical finding is edema of the lower limb, which is a unilateral edema of the lower limb. The oft-spoken Homanas sign, which we have learnt in our clinical classes, is almost obsolete because it is not specific and it is present in only around 35% of the patients. Homanas sign is sudden dorsiflexion of the ankle with a stretched knee producing pain in the calf muscle. Anyway, forget about the Homanas sign, but let us look at the prediction scores that we come across in the subsequent slides. Tenderness along the course of the deep veins is another important clinical feature. It's important that the edema in here is of the pitting nature, unlike the chronic filarial lymphedema. Superficial veins with collateral flow indicate deep venous thrombosis. Remember, varicosities are not collateral veins. This is a schematic representation of deep venous thrombosis. Look at the picture on the left hand side. It is showing the blood clot within the vein, and usually the blood clot forms around the venous valves. If you look at the picture on the right hand side, we see the two veins there, the one wherein the flow is very normal and all the RBCs are spread out with uniform flow. Whereas in a patient with deep venous thrombosis, the flow of the blood is impeded due to blood clots and the adhesion of the RBC over the clot. And this is how the normal blood vessel and the DVT blood vessel veins will look like schematically. These are some of the clinical presentations of deep venous thrombosis. The picture on the left hand side shows